Thank you. So the whole idea of not only this talk but this instruction course was to get rid of the complex. I remember when I was studying squint for my MS, it was to me so complicated and cumbersome that I told my hostel mates who were doing urology and psychiatry and other things that I wish somebody could give me an exam, MS into bracket without squint. And I promise never to look at squint ever again, and I promise I will give an affidavit that I will never treat a squint patient. So that was the fear that we had in MS, and we were hoping we would never get a case of squint in the exam. And we've come a long way since then, so it's no longer an untouchable. And I think that every general ophthalmologist should have a working knowledge of squint. And I'm going to talk about prisms and prism bars. So it's better to use these, which are not very expensive, rather than risk being behind bars for practicing this untouchability. So what are the things that we use? First of all, we've talked about the pseudo squints and the true squints in the beginning, and the comitant and the paralytic and the non-paralytic. There is a class of squint which we call heterophoria, or which causes asthenopia. So these are squints which are not seen, they are not apparent, they are not visible to you, but under certain conditions the child undergoes this, and they cause tremendous distress to the child and the family, even to adults, which is out of proportion to what you can see. You see the child is looking normal, and still the complaints of headaches and all sorts of things. So this heterophoria, or what we call latent squint, is a strain because in normal circumstances the brain says you cannot have this latent squint, so it does an extra effort to make the eyes fuse objects both for distance and near. That's why under normal conditions there is no squint seen when you examine the child, and yet the child, because of that extra effort, has got tremendous asthenopia, headaches and other things. This eye strain was called asthenopia. In ophthalmology we use big words to cover our small things, because if you say eye, nobody pays. You say ophthalmology, people pay a lot of money. So when you say child is suffering from eye strain, you don't get any pay, but you say the child has got asthenopia, they think it's something like cancer, and they will come to you. So von Graefe realized this practical thing, and Donders, in effect, both of them changed from eye strain, which was very pedestrian, to asthenopia, which sounds very exotic. So patients can have headaches, photophobia, blurred vision, occasionally even a diplopia. And these are always bilateral. So if you close one eye, everything will disappear, because naturally now there is no pressure of fusion. And it occurs in adults also. My private practice is very near a very big jewelry factory area. So all these people, jewelers who are working on these tiny stones all the time, focusing for near, very often have a little bit of esotropia. They complain of headaches, and the employers get worried because the productivity drops. So jeweler with esophoria might even lose his job, and similarly you cannot imagine a tennis player with exophoria. So that when he's focusing for distance, the eye goes out, he can never play competitive tennis. So you can have heterophoria or latent squint for distance, for vertical as well as horizontal. The symptoms vary during the day. Typically they are worse at the end of the day, or if the patient is unwell, or if there is tremendous amount of overactivity, typically during exams. And average ophthalmologists feel the child is faking it because he doesn't want to give the exams, or this is exam tension. It's not that. You need to confirm that there is no latent squint. Symptoms will worsen whenever the patient is unwell. Even in adults, pregnancy which lowers body resistance or lactation will cause a latent squint to become manifest sometimes. And typically the child is happy on Sundays. There is no squint unless the child has Sunday school. And the squint, of course, will disappear if you close one eye, or the symptoms will disappear. The moment from latent it becomes manifest, now there is nothing to hide. The squint is obvious. The brain is not going to try and fuse. It's given up the effort. So if a latent squint becomes manifest, the symptoms disappear. The child looks ugly. So how do we use two simple devices. One is called Maddox rod and Maddox wing. Again, these are extremely inexpensive, and I would urge every general ophthalmologist to keep this in your inventory. Maddox rod, what is the principle? Normally, as I said, a patient with latent squint will show no deviation because the brain says, "Aisa nahi kar sakte ho," you have to look straight. But by artificial means, if we dissociate the two eyes, by putting a Maddox rod in front of one eye, the brain finds it impossible to fuse because the two images are now completely different. So then the desire for fusion is suspended, the dissociation occurs, and now the patient is seeing two different objects. So now the heterophoria, the latent squint, you have converted into manifest, because heterophoria you couldn't diagnose. So you split it, make it manifest, and now you can easily diagnose. How do you do that? This Maddox rod is basically a glass rod or rods mounted on a disc like this. Usually it's red in color, you can have green ones as well. It refracts the rays of light in only one direction, so at right angles to its axis. So if you keep the Maddox rods vertical in front of one eye, the patient will see a horizontal line through this eye. So suppose this Maddox rod, so it converts a point of light into a, so you have a point of light in your Snellen's chart, you got a small dot light as one place. So you put on that dot light and ask him to look with one eye at that dot of light, and with the other eye you put the Maddox rod. So what will happen? He will see a point of light and he will find this rod, this horizontal, because you kept this vertical, bisecting this light. If there is no squint, so if the Maddox rod is placed with the grooves horizontal like this, there will be a vertical line. So if there is, so with the right eye, if the Maddox rod is in front of the right eye, you will see a vertical red line. So you ask him to focus on the light which is on the Snellen's chart here. With the left eye, patient fixes a spot of light at 6 meters, this one. Yeah? You can place a green simple glass in front of the other eye like this, or you can leave it as a yellow dot. So if it's orthophoric, if the rods are horizontal, you'll see a vertical red line. If it bisects the yellow or the green thing like this, it's ortho. If it is on one side, you know it is got a latent squint. Now this you don't have to remember, you can write it down also. If its line is to the right, it's iso. If the line is to the left, it's exo. So simple putting a Maddox rod with horizontal lines like this tells you whether it's iso or exo. It tells you there is a line on one side. So you know it's either iso or exo. Now you turn the rod the other way around so that now the rods are facing vertical, so the line is horizontal. Similarly, it will bisect the other line, the other yellow dot or the green dot. It will bisect it. If it's orthophoric, it will either go above it or below it, depending on whether it is hyperphoric or hypophoric. So this is a very, very simple test. Just by putting a Maddox rod and using a spot of light, you can diagnose a heterophoria or a latent squint for distance. Maddox rod can also be used not only to measure, but you can actually measure the amount of squint. So now what you do is you put prisms. So you put the Maddox rod, the line is going above or below or to one side. So now you put prisms which are correcting. How do you put correcting prisms? If it's exo, you put base in. If it's iso, you put base out. You know from physics that a prism bends the rays of light in the direction of its base. So when if there is a prism like this, it will bend the rays of light towards the base. So if it's an exo, you put it with base in so that the rays of light can go in and make the eye go in. And if it's an iso, you put it with base out so that the rays of light can go outwards and make the eye move outwards. In hyperphorias, you put prisms base down for a right hyperphoria. So this is something which you may have to memorize, but it comes with time. That this is all that you have to remember, where in a hyperphoria, where to put it. So base down for right hyperphoria and base up for right hypophoria. This is when you are trying to correct it with to see how much of prism diopter. So you know straight away that if you put a 10 prism diopter and it corrects, you know that the patient has got 10 diopters of latent squint. You can repeat the test by putting the Maddox rod in the other eye. If the patient has got no paralytic squint, it will be exactly the same results, unless there is a mild paresis. You can also use other devices like Maddox tangent scale and other things. We won't go into those details. You can also use it for cyclophoria. So just imagine a simple thing like this can be used for cyclophorias. Here what you do, you put the Maddox rods, red one and green one. So if there is no cyclophoria, you'll see two parallel lines. It's horizontal rods, so the lines are vertical. If the two lines are not parallel, but they are either turning towards each other or away from each other, you know there is a cyclical element, there is a torsion element over there. So some oblique is involved. Moving on to latent squint for reading, for near. So when there is a latent squint for near, typically the jeweler, typically children for studying for exams, usually have a latent squint for near. How do you test it? You have a simple device called a Maddox wing. Maddox wing only consists of a bar, of a metal bar over here, which separates the two eyes. So one eye is looking at the numbers and one eye is looking at an arrow. There is a white arrow pointing to some white numbers. And on one side over here are odd numbers and one side are even numbers. So in this, which you can't see, it says 0, 2, 4, 6, 8 on this side and 0, 1, 3, 5, 7 is written on this side. And just to make it idiot proof, on this where they write 2, 4, 6, they put EXO. And on this side they write ESO. So when you put the Maddox wing, give him to hold this and ask him where is the white arrow pointing. Now the white arrow is normally pointing on 0. But if there is an esophoria, it will point to 3 or to 5 or to 7, to odd numbers. And if it's an exophoria, it will point to 2, 4, 6 or something. The eye will move accordingly. So simple, if it's not on 0, 1, you straight away know that he's got an ESO or an EXO. And without using your brains, if he says 3, it's pointing to 3, you know it's an ESO. If he says pointing to 6, you know it's an EXO. Odd numbers are ESO, even numbers are EXO. Even if you don't remember that, the manufacturer writes EXO next to the even numbers and ESO on the other side. So it's a very idiot-proof thing to use. It doesn't require any learning curve. Everybody gets it in 5 seconds. Then what you do is you put prisms and see that the arrow comes to 0, 1. When it comes to 0, 1, that's the amount of correction which you want. So if there is no phoria, the arrow will point to 0. Yeah, so it's as simple. You're dissociating the two eyes. In the earlier one, you use Maddox rod to dissociate because you got dissimilar. Here you're separating the two eyes. So one is seeing an arrow, one is seeing the numbers. So this is what I said. If the arrow is pointing to even numbers, it's EXO. And patient should hold the wing, directing it downwards so the eyes are in a reading position. In small kids, you need to confirm that they're looking through the slit. Otherwise, they're very intelligent. They look from above it and they will see everything together. And if the patient is a presbyope, you need to correct the refractive error before you, otherwise he will see everything blurred, he won't see the picture. So, if the patient has heterophoria, you give what is called relieving prisms. That means helping prisms. Prisms which neutralize the deviation. Apex of the prism is always in the direction of the deviation or the base is in the opposite side. So as I said, if it's an exophoria, eye is pointing outwards. Therefore, you will give prisms which are base in or apex out. So exophoria, eye is going out, apex of the prism will also be out. Correct? Or base in. So that is how you remember this. It's very simple. So base is to be in the opposite direction. Horizontal phorias are corrected with base in prisms, as I said, for exo. You don't give the full correction. You give part of the correction. That means suppose now your patient is, when I do the Maddox wing and I find patient requires 12 prism diopters base in for an exophoria. 12 prism diopters. Now when I want to prescribe for him, what do I prescribe? Do I give him 12 prism? No. Patient will get headache. It's too much. So you reduce it by 1/3 or 1/4. So that means I will give a total of say 3 prism diopter. And I will split it. So I give 1.5 prism diopter in right eye, 1.5 prism diopter in the left eye. So you split it, so you reduce it and you split it. So in my prescription I will write 1.5 diopter base in right eye, 1.5 diopter base in left eye. Both will be base in. Similarly, if it's an esophoria corrected with 12, I will split it and write 1.5 diopter base out right eye, 1.5 diopter base out left eye. This is how you prescribe when you are giving for horizontal phorias. So every effort should be made to reduce this over time. As the patient gets used to the prism, when patient comes 6 months or a year later, see if he can accept a lesser prism. It is different for vertical phorias. In a vertical phoria, you must prescribe full correction because the eyes cannot adapt. In a horizontal phoria, 12 prism diopters, I am giving only 3 because the rest the brain can adapt. What we want to do is remove asthenopia or remove the eye strain. In a vertical phoria, our brain and eyes unfortunately are constructed in such a way that you can't adapt. So if the patient requires 10 prism diopter, you will give it full 10. Will you give both base down or base up? No. You have to give, example, right hyperphoria requiring 10 diopters for correction. I will give 5 diopters base down in the right eye. Remember that as I said, apex in the direction of the phoria, base opposite direction. So right hyperphoria, eye is going up, so the apex also will be up. So 5 diopters base up in the left eye, 5 diopters base down in the right. So you give opposite, base up and base down. If both vertical and horizontal, what will you do? First correct only the vertical, because that is the one producing the most phoria. It might give complete relief. If not, then you can correct the horizontal as well. Don't give anything less than 1 prism diopter. It's rarely necessary except as a placebo, and you cannot give too high a prism. If they are too high, like this patient who required 15 diopters, we give special prisms called Fresnel prisms, or they're called wafer prisms. I'm not discussing those in detail. So to summarize, you don't need the synaptophore. Simple things like the Maddox rods and the Maddox wing is sufficient for latent squints. You need to remember the principles that when you, for a horizontal phoria, you will give exophorias, you will give base in. For esophorias, you will give base out. If it's a vertical phoria, you will correct the full phoria. If it's a horizontal, you will undercorrect and call the patient repeatedly to see whether the prism requirement has gone down. So use prisms very, very easily. I have not even talked about prism bar, which is used for diagnosis of a squint. A prism bar is nothing except a set of prisms which comes. All the prisms have their base pointing in one direction and the apex in the other. So simple thing, even if you're doing a Hirschberg test, which is a torchlight test to see, suppose you do a torchlight and you find that the torchlight comes on the pupillary margin, you say approximately 20 degrees divergent. All you have to do is hold the prism bar in front of one eye and then do the Hirschberg and keep moving the prism bar up and down. Don't even have to remember which way the prism should be, base in or base out. Even if you don't, you'll find the squint. If you're holding it wrong, you'll find the squint worsening. So you hold it correctly and the squint is reduced, and bring the prism bar up or down till the squint is eliminated, and that is the amount of prism that is required. So even if you're using the prism bar, is a simple device to use to calculate how much of prism diopters a patient has of squint to decide on how much of surgical correction you want to do. Invite you all to the conference in Jaipur which we are doing with the American Association in December this year. Can we have my second talk?